Welcome back. Richard, today we are going to discuss a topic that we have talked about before, but it's always good to come back and revisit a topic because people sometimes have a hard time finding older podcasts where we talk about different things. But bipolar disorder is a largely misunderstood diagnosis, and it's frequently misdiagnosed. And my goodness, is maybe even more often self-diagnosed
Right.
by people.
Right. Yeah, we've noticed over the years. Well, first of all, we've noticed a dramatic increase
Right.
in the number of people diagnosed with bipolar disorder. I remember you and I faced this several years ago with children.
Right.
Prior to 2013, the diagnosis of bipolar. In fact, the diagnosis of bipolar disorder in children increased by 2,000% since 1995. So there's been this enormous explosion in the use of the diagnosis in children. It's also increased in adults. But even more alarming is that there are many people coming in and saying, I think I have bipolar disorder. As people learn about these diagnoses and can Google things, many people are coming in and they're concerned that either they or a significant other has this diagnosis. And I thought, well, given the increase, let's take another look at it, see what's going on in the field of bipolar disorder. And you can begin, and I think one of the reasons we have this problem is that the mood changes that we typically associate with bipolar disorder are so common. I mean, all of us have mood changes.
Right. Absolutely. And, a few months ago, we did a podcast where we talked about the differences between moods and emotions and feelings and all those.
Right.
I think that where this really comes to bear is in knowing the difference between those things. Mood is an underlying, usually long-term state, not even emotional state. It's just a state of being.
Right.
Your and so it's pretty stable typically over long periods of time.
Right.
And our emotions, however, are up and down all the time, usually dependent upon things that are going on around us. So, you can be in a good mood, a stable mood, we'll say, and have really high feelings, really low feelings, and then really angry feelings, really happy feelings, all of those throughout the day. But the overall mood is still sort of stable and maintains. Where we're talking about bipolar disorder, the difference here, as we kind of are going to get into, is that underlying stability is not there. So it's the underlying mood, not the emotions that change, but it's the mood that changes. And most of the time people talk about they have mood swings, really what they're talking about are emotional swings.
They're really talking about their feelings or their emotions at the moment.
Right.
It's how I feel right now. We talk about, we don't look forward to Monday mornings. Many people, they sort of feel down on Sundays because they don't really look forward to going to work on Monday. Or, you wake up some days and you just don't feel very good. I mean, you just, kind of a blah day. We call it a bad hair day or something like that. And sometimes we're sad for no reasons. And other times we're happy for no reason. When you think about it, I don't know why I'm down today, but we can just as easily say, well, I don't know why I feel good today. There's nothing different. I just feel a little bit better today. Some days you have patience with other people, and some days you don't have much patience with other people. And so all of those little fluctuate, those day-to-day feelings will change from time to time. And they change because I think a good way to think about it is that our feelings are governed by, they're affected by the chemicals in our brain.
Right.
And we have over 100 of those chemicals. We don't really understand them very well because we're only now we're just beginning to get the technology that we need to study those brain chemicals. Mm-hmm. But our brain chemicals come from the foods we eat. Right. We extract brain chemicals from the foods we eat. And unless you eat the same thing every single day, because most of us eat a variety of foods, the circulating brain chemicals are going to change from day to day. So maybe it's affected by our diet. Maybe it's affected by the moon. We're hearing about the blood moon and all that stuff going on these days. Maybe it's affected by we really don't know. But we know that our feelings and our emotions fluctuate from day to day, and they fluctuate within a day.
Right.
Okay. But those little fluctuations are not what we're talking about here.
Right. No, absolutely. And it's really, when you think about what most people say when they talk about mood swings, what they're talking about is some reaction to something that happened in the
Right.
immediate, setting. And so a lot of times emotions, like you said, are based upon what we eat. They're based upon and based upon what we're experiencing at a particular time. So it is very much a state condition. It's like whatever state you're in at that moment is going to help, determine what your mood is. And so you could have somebody who's severely depressed,
Right.
and you can put on a comedy and they can laugh at the comedy. They can even enjoy the movie, but they're
Mm-hmm.
still depressed.
We're still depressed, right?
And that's what makes things so confusing for folks sometimes because, well, how can he be depressed when he seems to be really enjoying what's going on over there? Or how can she be depressed if, she's, doing this or that? Because depression is the underlying mood, and it's not their surface level emotions that they're feeling at the time.
Right, right. And that's the important distinction. We're talking about a mood versus an emotion or a feeling that we have moment to moment. Mm-hmm.
Right, absolutely. So one of the articles that we posted in the show notes talks about different symptoms associated with bipolar disorder, and it kind of goes into a little bit more detail of some of the things that we're talking.
And the other one is from the National Institutes of Mental Health, because we thought, well, let's start with some kind of broad definition of what is bipolar disorder. And bipolar disorder is also known as manic depressive illness or manic depressive disorder. It was once referred to as that. Bipolar is two poles, mania and depression, and people switch back and forth between those two things. But it's National Institutes of Mental Health defines bipolar disorder as a mental disorder that causes unusual shifts in mood, energy, activity level, concentration, and the ability to carry out day-to-day tasks. So just in that definition, you see that it's much more than how I'm feeling, that I'm kind of down today. There's much more to bipolar disorder than just mood. We have to think about energy level, activity level, the ability to concentrate. And we'll talk about those things as we go through this. Okay.
Absolutely.
The other thing is that less than 3% of the population will experience this in a single year. The actual rates of this are pretty low when you think about it. So it's pretty low. The problem is that people who actually have the diagnosis are severely impaired by it. And I think that's why bipolar disorder has come to the attention of professionals as well as lay people. People are concerned because the bipolar disorder that you hear about ends up being a pretty significant life event.
Absolutely. And many times that is because, folks with bipolar disorder, like with many other mental health conditions, still aren't really receiving treatment.
Mm-hmm.
When it comes to bipolar disorder, many times folks go decades.
Right.
The first episode, whether it's a manic episode or depressive episode, before they're correctly diagnosed.
Right.
So they're inadequately treated, inadequately identified and diagnosed, and they go a long time without adequate treatment. And so, these symptoms do worsen, and it creates a great deal of problems for many people.
Right.
And as you said, the criteria or the mood swings or the mood poles are mania and depression, and either end can cause significant difficulties for the folks.
Right. And the other problem is mania can look like many other things. It can look like ADHD, hyperactivity, and depression can look like many other things. And so is it just depression? So then you have to look for, is there a cycle of mania? So it does take time to sort out this diagnosis. And it can be a long time before the diagnosis is actually clarified. And that's true developmentally as well, because in young children and even in adolescents, this can mimic many other diagnoses. And you just don't know. It's bipolar disorder presents very differently in young children and young teenagers than it does in adults. So, but there are three types, and I think this is important. The other thing is there are three types of bipolar disorder.
Right.
And the reason I like to talk about this is that when you talk about the first type of bipolar disorder, when you talk about mania, you're talking about mania that lasts for 7 days.
Right.
And that's a pretty strict criterion.
Absolutely.
You're not just up 1 or 2 days. This is a sustained state of being.
Absolutely. And yeah, bipolar disorder type 1 is sort of the stereotypic traditional bipolar disorder that most people talk about. And look, the reality is that to meet criteria for bipolar disorder type 1, really all you ever have to have had is a manic episode.
Right.
Bipolar disorder type 1 doesn't even require the experience of a depressive episode.
Right.
You have to have had a manic episode. And as you said, a manic episode has to last at least 7 days, unless the symptoms are so bad that you have to be hospitalized.
Exactly.
Then it's medically, you're sort of medically taken down from the manic episode. And so we're not talking about, I was fine this morning and then, I was in traffic and all of a sudden I'm raging out in traffic. And then I get to the office and I'm, in a better mood because there was some cake. And so I felt better. That's a mood swing. That's a emotional swing, but that's not what we're talking about with mania. So they have to last at least a week. And if it's a depressive episode has to last at least 2 weeks.
Right.
It's not just, I was feeling down for a couple of days.
Even a couple of days, exactly.
Episode has to last 2 weeks.
That's right. And these
long term, again, remember, if we think about moods as sort of that long term underlying stability, for something to last a week and then go away, that's unstable. That's a mood fluctuation. That's pretty significant when we're talking about mood, not emotions, but when we're talking about mood.
That's right. So to have this first type, this bipolar, these manic episodes are so significant, as you say, people are often hospitalized during these episodes because they're so dramatic, they're so significant, they're so problematic that many people, and this has happened to some people I've known, who, there's almost a complete break with reality during the manic episode. So these are if you're talking about bipolar disorder 1, you're talking about a very significant manic episode, long lasting, and you're talking about a very significant depressive episode. So there would be little to question if somebody's having true mania or a 2-week depression. There aren't many questions left.
Absolutely. And the idea that they build up sometimes, they happen over a period of time. Sometimes there's sort of a ramping up that can happen. But I like that you said the break from reality, because we used to refer to, or mania used to be referred to in much the same kind of terms as a psychotic break.
Exactly.
We call it a manic break or a psychotic break. And there is this relationship between it just sometimes, while sometimes it ramps up, sometimes it just happens.
Right.
And and it's unpredictable, and there's things that you can do to try to reduce the likelihood that it will happen, but by definition, it has to cause a serious impairment. It has to cause a significant impairment in functioning to meet criteria for a manic episode or a depressive episode.
And those types of mania and depression that we associate with bipolar 1 typically are impairing. And there's no question that they're impairing. Okay.
Absolutely.
So bipolar 1 is pretty dramatic, pretty easy to spot.
Absolutely.
A little more confusing with bipolar 2.
Right. Because with bipolar 2, all the symptoms are exactly the same.
Right.
Exactly the same. The only difference is that they call it hypomania instead of mania. Hypo meaning less than. So it's just under mania. And so the symptoms are there, but there's not a significant impairment in functioning. And what's fascinating to me, and one of the reasons I always love teaching students about bipolar disorder, is because there's only a couple of conditions, this diagnoses that we can think about that doesn't require an impairment in functioning. And hypomania is one of them.
Yeah.
It's one of the only diagnoses, things that we identify in the field of mental health that doesn't require an impairment in functioning. So if a person is experiencing all those symptoms of mania, but they're still going to work every day, they're maintaining relationships, they aren't getting into any trouble, they're not spending more money than they should, they're not engaging in any inappropriate behaviors, then that could be hypomania, but it's probably not mania because there's not that impairment in functioning.
Right, that's right. And it usually doesn't last as long, and it's usually not as dramatic. It's not as intense, okay? And it's the same with depression. It doesn't last as long. It's not quite as intense, but I think you're right. If you think about it in terms of impairment, these are less impairing characteristics than we have with bipolar 1.
Right,
absolutely. And then the third type is called cyclothymia, cyclothymic disorder. And this is, again, a little more difficult to spot, although there's a time period here that does make it easier.
Yeah, and I'll say I've never, I don't know that I've ever diagnosed anyone
I don't think I have.
with cyclothymia. I've diagnosed with folks with the depression version of cyclothymia, which is something called dysthymia. It's now called persistent depressive disorder. But these are mood episodes that last a very long time.
Right.
It's a very low level mania, hypomania, or a very low level depression that lasts a year or two. And in fact, for adults, it has to last 2 years. One of these episodes has to last 2 years. And for kids and adolescents, it can only has to last a year for the diagnosis. But we're talking about very long-term persistent presence of these symptoms.
Right. So in each of the types, bipolar 1, bipolar 2, and cyclothymia, you have the same characteristics of mania and depression. In bipolar 1, it's very severe. Bipolar 2, a little less severe. And in cyclothymia, even less severe. It's hypomania. It's both characteristics, but very low levels. The difference being very long lasting. Okay, for cyclothymia. Okay, so before you jump to conclusions, remember the three types and remember that intensity and impairment become the issues. So the article we posted has what I like about it is, you wonder, is it bipolar disorder? Well, this author does a very nice job of listing 13 signs and symptoms of bipolar disorder that may be of concern.
Right. And the first is the mood. And here we're mainly talking about mania, right? And so for mania, there's that elevated or heightened mood that's usually very high energy.
Right.
As they're working up, and sometimes a person can start in sort of a hypomanic state, and if they're not careful and if they don't recognize it and do something about it, it can lead to mania. So when it's in that hypomanic phase, it could be very tolerable. The person is working a lot, they are not really needing much sleep, but they're feeling very good. And Richard, I know that you've had this experience. A lot of times people who are in hypomania, they love how they feel.
That's right. The problem with this is they enjoy the energy, right? Because you can be terribly creative, terribly productive. And I think we can see this with some artists. You hear about artists working for 3 or 4 days without sleep, and they just are extraordinarily productive. And many people like that kind of elevated feeling. But it's still hypomania and can be a serious problem.
Right, because especially once it gets to mania, to a manic level of energy.
Mhm.
As you said earlier, there is this somewhat break from reality that lasts a considerable amount of time. And we're talking about people who sleep 1 or 2 hours a night and but still are like going all day long. And they talk. Well, we'll get to some of the other symptoms, but that they feel good, but they are just constantly moving.
Right, right. To the point where it's alarming.
Right,
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 right. The second one is the inability to complete tasks.
right.
Now, be careful with this one because most of us have, many of us have trouble completing tasks, and we go, well, I do that. Um, but this is, remember, we're talking about intensity here.
Right. Yeah. And
Okay.
so here we're talking about like a person going from task to task to task. And let's then very quickly make sure that we note that this is a different from typical. So we're not talking about an ADHD person who is going from task to task to task sort of impulsively.
Right.
What we're talking about is the person normally completes what they're doing and manages things pretty well. And now they're in this period of time where they're not doing that. They're not completing what they need to complete. They're going, especially taking on more than they can handle. They take on more and more projects or tasks that they're going to do, and there's just no way that they can do it.
And if you think of the cycles, when you're in that hypomanic or manic phase, you want to jump in and get a bunch of stuff done. But that only lasts for a few days, and then you slip into depression, and then you don't feel like doing anything.
Right.
So it's start, stop, depending on the cycles that you're going through. But these are impairments. These are, spouses come in and say, well, he has 1,000 things, the garage and the room and the playroom and the kids' room. And you get these complaints that go way beyond, as you say, ADHD or simple distractibility. I mean, these are people who have during the manic phase, they'll take on these gigantic projects. Like, I'm going to redo a room, and they start the room and it's unfinished after a year.
Right. Absolutely. Now the third is a little bit difficult to talk about on a family friendly
program.
But there is a phenomenon that we often see in people who are especially experiencing a manic episode, simply called hypersexuality. And so the person becomes very provocative. They become very risky in their experiences with other people. And throughout the course of bipolar, on mania, the mania end, you can have that type of presentation. But on the other end, then you may have complete avoidance of any type of intimate relationship with anyone. And so you go from, lots of partners, risky behaviors on one end to the complete avoidance and disinterest and inability
Right.
on the other end.
Right. And when you think about mania or hypomania, I want more and more and more and more and more. Well, it's not unthinkable that it would also affect your sex life or eating or the use of money. It affects all areas of your life, including your sex and interpersonal relationships.
Absolutely. Yeah, there's a lot of risk-taking behaviors that happen there. So now the next is depression. And that is, the depression, like we talked about, mania on one end, depression on the other end. And it's very similar to depression that we think of traditionally.
Right.
But our treatment for this depression associated with bipolar disorder is very different.
Yeah, here there's a big caution flag that should go up with depression because the depression looks the same. I mean, depression is depression. But when the depression that's associated with bipolar disorder is a little different. And one of the big differences is that it may not respond to antidepressant treatment. In fact, it may make it worse. We used to talk about that with children. And I know that I think the same thing exists in adults. Even if you treat the depression, even if it's successfully treated, you treat the depression, but it allows the mania to appear, to percolate to the surface. And so depression in bipolar disorder has a little different flavor than it does in unipolar depression.
Absolutely. And, and that's a big risk because you have, you treat the depression with antidepressants and you have that risk for creating a manic episode, which is the phase or the time period wherein the person is most dangerous to themselves, most at risk for harming themselves. And so we have to be really careful of that. And I think that this also introduces what is really a big concern for people early in their identification of bipolar disorder, because many times, at least 50% of the time, sometimes more depending on the research you're looking at, they have a depressive episode first. So if the person has never had a manic episode, but they're sort of, and this is hard to, you have to think about it four-dimensionally because of time. If the person is experiencing a depressive episode, but biologically, they're bipolar. They just haven't had a manic episode yet.
Right.
And so their first episode is depressive episode.
Right.
And then we don't know that. And so they get placed on antidepressant medications. That person is at risk for having a manic episode. And in fact, when you're thinking about diagnosing mania, that's one of the things you have to rule out. You have to say the person did not have a manic episode simply because they were placed on antidepressant medications.
Right.
It can commonly happen. And it can create sort of this experience of a manic episode simply by having the antidepressants. So it's really challenging to determine. So, you have to do a lot of history to make sure that there is no family history of bipolar disorder and that there's no genetic predisposition for that before you're giving that initial medication treatment for depression.
Yeah, we can get into some difficulties there. So now another characteristic is irritability, and you can imagine again, if it happens that the depression and the mania happen at the same time, now you have sadness with energy.
Right.
Okay, and I know of a case where an individual had some dealing with a service provider, and was dissatisfied. And I guess a couple hours later, got back into his car, drove back to the place, stormed in, and had this huge tantrum, blaming the person who provided the service. I forget what it was. It was some haircut or nails or something involving a personal service, and just had this huge scene in the middle with all these people standing around. Again, that's pretty unusual behavior. So it's not the typical irritability that we see. It can be on public display because, again, there are few boundaries and that intensity comes back.
Absolutely. And it kind of flows into the next one, which is rapid speech. And we're not just talking about fast speech here, we're talking about pressured speech. And I think diagnostically, it refers to it as pressured speech. And so while a person may talk fast, what we're referring to here is like they just can't seem to talk fast enough to get everything out. It's like they're really forcing out the words because they have so much to say. They have so many things that are sort of going through their mind. We'll talk about racing thoughts. There's like so much happening in their mind that they just can't get the words out fast enough.
Right. It's not conversational speech. It's not like, oh, wait, let me finish. That's conversational. You're asking for a little more time. They will talk over you, and they'll keep talking. Even if you're talking or other people are talking, they will keep talking. And then suddenly they change subjects and they're talking about something else. Again, they just have to get it out. Mm-hmm.
And then there's a great deal of disorganization that comes about with this as well. So the next one is talking about like a loss of time. And this is oftentimes associated with, really getting into a particular thing that they're doing, or perhaps even because of that, jumping from thing to thing to thing, they start missing deadlines, have difficulty sticking with the schedule. They're very disorganized, and again, can create a lot of problems at home and at work.
Right. And earlier you talked about impairment. You have to have impairment. And one of the places where impairment shows up is in this eighth one, where people have trouble at work
Right.
because the characteristics they bring these characteristics to the workplace, and you talk about time. They have trouble showing up on time. They have trouble meeting deadlines. They're less productive than coworkers. Their life is sort of disorganized, and there is no good sense of time and schedule and how much do I have to do today. And then they have interpersonal problems with either with coworkers or with supervisors.
Yeah, and it's all again related to that. Even though they're taking on more things, they're
Mhm.
not completing anything. We talked about that earlier, and so it does create a lot of problems with time, which was the seventh one, and with work, which is number
Right.
eight.
And then of course, number nine is alcohol and drug abuse. Many people with bipolar disorder know that there's something wrong and they can't get the right medications, so they begin to self-medicate. And the most will self-medicate with alcohol. At least that's what current research is suggesting. And again, it makes sense because during the manic episode, they use alcohol to slow down a little bit. During the depressive episodes, they drink alcohol or do drugs to improve their mood. Okay, so yeah, of course, that would make sense.
Right.
Mhm.
Now, 10 and 11 sort of go together as well. And that is number 10 is erratic behavior and 11 is grandiosity.
Mhm.
Um, Many times people with bipolar disorder, especially when they're in that manic episode, will experience huge inflation in their self-esteem. Um, they will oftentimes feel as though they can do anything. But maybe more related to the erratic behavior is that they do really unusual and problematic things. And so we often hear, for example, about people who have been Baker acted from the side of the interstate where they're, walking down the interstate, naked or in the middle of the night or, you know, at these strange times and in circumstances, um, just doing very bizarre, weird things. And and that type of erratic behavior oftentimes is what leads to the hospitalization during a manic episode.
Right, right. And you're right, that goes hand in hand with grandiosity because, and that again is one of the characteristics that we talk about in children because when parents are saying, well, does my child have bipolar disorder? And one of the things we look for, two of the things we look for is irritability, which we mentioned earlier, and grandiosity. You know, these are kids who think they can fly or they can climb up on a roof and be Superman or Batman. It's a delusional grandiosity, not narcissism. It's a delusional grandiosity. And they're pursuing these grandiose projects rather than everyday things that can be accomplished. They have these grandiose ideas of what they can do. Another place where it turns out is that people who have grandiosity frequently consider themselves above others or above certain kinds of job. Well, I would never do that. If I'm going to be there, I have to be the administrator, or I have to be the president, or I have to be the CEO. Oh, that's beneath me. You know, that idea that I'm the best and I'm better, and anything else is beneath my dignity. I can't do it. So also look out for grandiosity.
Absolutely. Now the next one is probably also an area where we actually focus the most for treatment, not non-medication treatment, and that is there's a lot of sleep related issues. Um,
Right.
we know that in depression can either lead to people sleeping too much or not enough or having difficulty falling asleep. And with mania, not just that they sleep less or don't sleep as much, is that they don't need as much sleep. That energy level that we talked about earlier. And so one of the main treatments that we focus on to reduce the risk for a manic or depressive episode is maintaining a healthy sleep cycle.
That's right.
Um, Many times, if a person with bipolar disorder can maintain a good sleep cycle, good routines, healthy eating, and all that kind of stuff, as you were talking about earlier, many times we can reduce the risk of either of these mood-related episodes. But it's still difficult.
Right. Yeah, with sleep problems, it's a little cause and effect problem here. Is that does the disorder cause the sleep problem, or does the sleep problem cause the disorder? it doesn't matter which way it goes, you have to address sleep. If you can address sleep and get a person on a regular sleep cycle, it's going to improve. It's probably going to result in improvement in symptoms.
Absolutely. So,
Mhm.
and then the last one here is that flight of ideas that we were talking about earlier, that, the mind is racing, it's moving fast. And many times people, especially in that manic episode, they will talk about their thoughts are just going 90 miles an hour
Mhm.
constantly, 23 hours a day, and
Right.
they're not sleeping because they just can't stop their thoughts. And it's not necessarily um like psychosis, psychotic related thoughts, like weird, bizarre thoughts. It can be, you know, life related thoughts, but they just are going really fast, and there's just a ton of them, and they can't keep them, again, they can't keep them organized. They can't sort of stop them or slow them down. And that leads to that pressured speech that we were talking about earlier. And some of those, and it can affect the sleep and all that.
Right. And as we go through these, as I read through them again, these 13 ideas, it's the manic episode that I think is both the manic episode and the depressive episode are significant and impairing.
Right.
The manic episode is simply more obvious.
Right.
When a person is in a manic state, the whole world can see and hear that there's a problem. Whereas the depressive episode, we tend to withdraw and hide and stay inside, and it's less obvious. But there would be, if it's bipolar 1, there will be little doubt because of the severity and intensity of the symptoms.
Absolutely. I remember working with this teenager once whose mother had bipolar disorder, and he
Mhm.
would talk about times where, um, how he had such difficult time, like having friends over and things like that. But he would have to gauge when to have friends over by the mood that his mom was in. He said that there would be times when she would be secluded in her room, and they would sort of literally crack the door open and slide food in, and because she just wanted it dark and she wanted to be alone. And that was when she was in those depressive episodes.
Impressive, right?
um, those would be times when it'd be okay for his friends to come over. But when he said that when she was in a manic like episode, he couldn't have his friends over because she was just so high energy, very provocative, even with his friends, and very inappropriate in many ways. And it made him very uncomfortable, and he didn't understand it. So we had to talk about it a lot in sort of
Right.
really for what those symptoms were, and so that he didn't see his mother in this really negative way, that she was struggling with something that she wasn't able to control,
Mhm.
and that she needed some more help with it.
Right, right. Yep.
So bipolar disorder, again, it's not just mood swings, which is why most people think that they have bipolar disorder. That's why a lot of teenagers will come to us and say that they think they have bipolar disorder. They think their mom has bipolar disorder because, she has mood swings. Um, but usually, most of the time, what people are talking about with mood swings are not the type of mood swings that we see with bipolar disorder.
Right, right.
So, uh,
Yeah, it's hard to miss if it truly is. Although, as we said, bipolar 2 might be a little more difficult because it's not quite as intense. You don't have the impairment. Cyclothymia is even less intense, but much longer duration. So again, it would be the chronicity of it, the long 1 or 2 years of symptoms. It's like teenagers. You have to have these symptoms for a year. And there's little doubt when parents come in and they talk about their children. There's little doubt if it's cyclothymia, because parents will say, he's been like this for a couple of years. Well, then that's not a simple change in emotion or feelings that are event related. That's could be a more serious problem.
Absolutely. So check out the articles. The links again are in the show notes, and let us know if you have any questions. But you know, bipolar disorder is a very serious condition that does need more attention, and we need to watch out for it.
Exactly. Okay.
Well,
This
that
is the end of Mental Health Awareness Month.
it is. This is the last.
May is Mental Health Awareness Month, so we're happy that we could talk about this sort of increasingly prevalent mental health condition.
Absolutely. So, all right. Well, that is it for today. Until next time, stay happy, stay healthy, and forget to be afraid.